Hi everyone, my name is Rachel Thorpe. I'm happy to be here presenting this work on donors and non-donors perspectives on genomic testing of donated blood. I'll be presenting some empirical findings, and then Vera will take over and talk a little bit to you about the ethical implications of this work. And I would just also like to thank Mel Hyde and Barbara Massa for inviting us to be part of these talks. So increasingly, blood collection agencies are looking further into the blood that they collect. In Australia and internationally, the demand for phenotyped and genotyped blood is increasing because of changes in clinical practice, with this trend expected to continue. Techniques like next generation sequencing are enabling greater proportions of donor blood to be genotyped in a more cost-effective manner, which means that blood collection agencies will be able to genotype more of their donors and potentially identify more information about donor blood. So genomic studies are also focused on identifying genetic markers of importance to donor health, such as markers for fainting or related to iron metabolism. But we actually don't know very much about what donors would think about receiving this kind of information through blood donation. So as the technology is improving and the cost of genomic testing is becoming cheaper, I think it's really important to sort of look at, well, what do our donors think about these things? How can we make sure that we, as people who work for blood collection agencies, bring the donors with us on this journey? So there's quite a bit of research on donor perspectives on participating in biobanks and use of their blood samples for research. So there's a number of studies where donors have been asked their perspectives on donating extra samples for biobanking and using their blood for research. And obviously there's many countries with established blood donor biobanks. So we know that donors do participate in biobanks. They're generally quite positively oriented towards them. And this tends to be because of the trust relationship between blood collection agency and donor. So that seems to be quite a key marker of willingness to participate in biobanking. So not everybody participates. We know from research that participation in biobanks tends to be mediated by demographic characteristics like age, gender, and ethnicity. There's also the question, I guess, of whether blood donors consider donating blood for research or biobanking as being consistent with their reasons for donating blood and with the mission of a blood collection agency, and that's something that we don't know much about. So in this empirical work that we conducted last year, we wanted to know, well, what do donors and also eligible non-donors know about the type of testing that's already conducted routinely on donor blood, and what are their perspectives on the types of tests that could be conducted in the future, and what are their views on whether receiving this kind of information through blood donation is appropriate and whether they've consented to it. And having an understanding of donor perspectives on these questions can help blood collection agencies to plan for communicating with donors, for a strategy for for how they can do these things, with maintaining trust with donors and also with the public. So we decided to use a qualitative approach for this work. We used focus groups because we wanted to understand and generate insights through group discussion and interaction on these topics. So drawing on previous research, we decided to develop scenarios based upon current and possible future genomic testing of donor blood. And we did this to, get people talking really about topics that we sort of know from the literature that people don't really know very much about. So we encouraged participants to sort of put themselves in the shoes of a donor. Using scenarios can help to encourage participants to raise self-identified issues and allows them to bring their own behaviours, opinions and beliefs into the discussion. So our participants were 24 donors and 24 non-donors. We conducted 8 focus groups, so 4 with donors and 4 with non-donors, and we decided to separate the donors from the non-donors in the focus groups because we knew that donors would have a lot of knowledge about blood donation that non-donors wouldn't have. So they were aged from 18 to 65. We had a fairly even split of females and males, and we deliberately sampled to try and get ethnic diversity in our sample as well. So 3 scenarios that we composed were, the first one is that a donor receives a communication about having a rare blood type, and this is something that already happens. The second one is something that doesn't already happen, which is that a donor receives a communication about having a genetic marker that means they aren't able to replace the iron in their blood as fast as some people are. And the communication suggests that the donor only donates whole blood 2 times a year as opposed to the maximum number of 4 times a year allowed, or donates plasma instead. The third scenario was one, again, that is not something that would currently happen at Lifeblood, where the donor receives a communication, a phone call, informing them that testing of their blood has identified that they're at a higher risk of developing bowel cancer, and asks them to discuss this with their doctor. So the focus groups were recorded and transcribed and quality checked. And they were coded using an inductive approach and then analysed using thematic analysis. So we found overall that both the donor and the non-donor participants tended to consider testing of donor blood, and in particular the appropriateness of it and the receipt of information based on that testing from the perspective of what they thought they would expect a blood collection agency to be doing with their blood, which we've sort of here termed the core purpose of a blood collection agency. And as part of that, they thought about, well, what have I signed up to as a donor, and what do I think I'm signed up to? Like, as part of this sort of idea of a donor organisation contract, what do I think that that I've agreed to my blood being tested for? So through discussions, they also identified boundaries to this core purpose. They also thought about, well, what is the role of a blood collection agencies within the broader healthcare system? And also the idea of receiving health information through blood donation as a form of preventative health. So these were the main themes that we identified in our analysis. So looking at findings from discussions around the rare blood type scenario, we found that participants generally thought that it was appropriate to be testing for Lifeblood to be testing donor blood for rare blood types, because this testing was related to recipient health. So they thought this testing would be a really good thing for recipients, that it would improve transfusion outcomes for recipients. And so they thought that it was completely inappropriate type of testing for Lifeblood to be conducting. And they also thought this was really good for the donor, because they perceived that being told that you have a rare blood type actually makes you more valuable as a donor. It makes both you more valuable and also your donations more valuable, because of having additional information about how it's helping and who it's helping, and because they would feel quite special. when we looked at whether people thought they had consented to this testing, we found that generally participants perceived that as a donor, you do consent to your blood being tested for purposes related to recipient safety and to receive information about this. However, none of the participants were aware that red blood type testing is undertaken on donor blood currently. So while they thought this type of testing was appropriate and they did think it was covered by existing consent processes, they didn't necessarily think that it was informed consent. So when we look at the poor iron metabolism scenario, so scenario 2, when we look at whether people thought this was appropriate for a blood collection agency to be conducting, we found that participants generally perceived this information and advice based on it also to be acceptable and appropriate because they thought that it was demonstrating concern for the health of the donor and they thought it would benefit the donor's health. And in fact, some people thought that actually the organisation has an ethical responsibility to be providing this type of information to donors because they thought otherwise people might be compromising their safety, donating too frequently. Some people thought about the appropriateness of this information through the concept of the sustainability of the blood supply and the quality of the donated blood. So they sort of perceived that through providing this kind of information to donors, this would improve the quality of donated blood, and they perceived that it would enable donors to donate for longer because people wouldn't be deferred as frequently. So they thought that this had benefits for the sustainability of the blood supply, which they saw as being very much part of our core purpose. However, in discussing the scenario, participants also identified boundaries to the kinds of testing that they thought were appropriate for a blood collection agency to be conducting. So this quote here, the donor says, "As long as the tests are limited to things that are for protecting the safety of the donor and the recipient and the quality of the blood as well and nothing else, then I would be happy with that." So you get this sort of sense that this person feels that this is sort of reaching the limit of the acceptability of testing of donor blood. So then when we looked at whether people thought they'd consented to receive this information, we found that people were divided about this. Some perceived that there was no need for additional consent, that this was covered because the testing was related to donor safety. However, other people thought that this kind of testing should be optional and that donors should be given information about it and to be allowed to opt in or out of this testing being conducted. So moving on to scenario 3. Again, people were quite divided about whether they thought this kind of testing was acceptable for a blood collection agency to undertake. Some people perceived this testing to be appropriate because they thought the information was of benefit to the donor's health. And they saw this kind of information as part of a continuum of information that a blood collection agency could obtain from blood. So in a way, they thought that it was making the best use of this resource, making the best use of technology and, providing the best value from donated blood. They sort of felt that it would have benefits to them for their preventative health as well. However, some people also noted that receiving this kind of information through a blood collection agency may have implications for the donor organisation contract because you're providing somebody with health advice. Does that change them from being a healthy donor to a patient? So this is sort of kinds of issues that were raised through this scenario. And some participants did not think that testing for disease markers was appropriate because it was not directly related to the core purpose of a blood collection agency. So they felt as though this was not directly related to the safety of donation for donors or recipients, or to the quality of blood. They also felt as though the impact of receiving this information may be problematic for health insurance and life insurance and privacy. They also were concerned that while technology is making it possible to undertake this testing, donors wouldn't know what to do with this information. And yet generally that potentially it could confuse people as to what is the purpose of a blood collection agency. So this quote, the second quote, the donors saying, "I think we go to the blood bank to donate blood and not to get a health test." So those sorts of concerns were raised by some participants around, well, what are the boundaries of the purpose of a blood collection agency within the broader healthcare system? And what is the expertise of a blood collection agency as well? Generally, the participants did not believe that they had consented to receive this kind of information through a blood collection agency. Some participants felt as though this testing should not be undertaken at all by Lifeblood, and others thought that this testing was acceptable if the donor had consented to it being conducted. So just to summarise those findings, the participants tended to think about genomic testing through this idea of what a core purpose of a blood collection agency is. And so they thought recipient safety was definitely part of the core purpose, as was donor health. Making the best use of donated blood was also identified as being part of the core purpose. Making sure that donations were of good quality, and maintaining a sustainable blood supply. However, testing for disease predisposition was not perceived to be directly related to the core purpose of a blood collection agency. However, it was indirectly related through having a potentially positive impact on donor health and enabling blood collection agencies to make the best use of donated blood. They also could see benefits for receiving this kind of information through blood donation for their own preventative health, such as identifying markers for disease and enabling them to take steps to prevent disease from progressing. But concerns were expressed around the role of a blood collection agency within the healthcare system and the fact that they didn't perceive Lifeblood to have expertise as being a healthcare provider. However, they could see that receiving information through blood donation may complement primary healthcare. So just to summarise, participants tended to view genomic testing of donor blood positively, but wanted transparency about current and future testing. And both donors and non-donors tended to view testing of blood as appropriate when it assists the core purpose of the blood collection agency. However, testing that doesn't directly optimise donor health or recipient safety was met with mixed feelings, including concerns around privacy and data security. And consent and communications with donors are important drivers to this testing being accepted. And now I'd like to hand over to Vera to talk a little bit more about the ethical implications of our findings. Thank you.
One thing we found very interesting in these empirical findings was how, when taking on the viewpoint of a voluntary blood donor, the study participants' views on appropriateness of a genomic test expanded from reflecting on the possible health benefits to individuals to social and ethical implications. So in these discussions, the genomic test and consent were reviewed in terms of what is good for the donor relationship and what should be blood service core purpose in the society. We would now like to discuss a bit these ethical reflections with the help of previous sociological research and theory. With these two quotes, I would like to introduce discussion on ethics of blood-donor relationship as a case of civic solidarity. Titmuss introduced the idea that situated within the context of a welfare state, voluntary blood donation can be perceived an act of civic solidarity. This gift is a response of the healthy members of the public to the health needs of blood transfusion patients. And here is how Titmuss further elaborates that gift relationship between the healthy donor and intended recipient. There is nevertheless a vague and general presumption of a return gift at some future date, but a gift that may not be deliberately sought or desired by the individuals concerned. As with voluntary blood donors, few people, when well, wish to be ill. Few people desire operations, blood transfusions, inpatient treatments, or social care from social workers. So the sense of a moral duty, of solidarity, to donate blood to help fellow citizens comes from the comparative appreciation of being in good health for now, and simultaneously reflecting on the possibility of becoming a patient one day. But also with anticipation that donation does not affect donor's health status. So when solidarity is a reason for to donate blood, there is an assumption that health is social, a relational matter, something concerning questions of how to share responsibilities of care. Here the quote from Barbara Breinsack describes solidarity and how it engages us thinking the ethics of healthcare system. If solidarity is understood as a practice expressing the commitment to accept costs to help others with whom we recognize similarity in a relevant respect, then this leads us to ask an even wider question that concerns the organization of healthcare as a whole. If persons are seen as relational beings, whose boundaries are porous, can we isolate the benefit and well-being of some from the fate of others? So with these ideas in mind, if we now go back to thinking about the participant viewpoints, we can identify questions of solidarity and its boundaries being negotiated. Donors were thinking of becoming recipients of genomic test information that had potential to change their health status. First, it seemed that receiving genomic information for the purpose to maintain blood donors' health could be received to strengthen donor relationship of solidarity. This kind of genetic information was used to stay healthy while donating blood, was something that was part of the donor responsibility that aligned with the donation purpose to help the patients. But there were still also some issues about when it was still about solidarity, if those only who were in good health could be recruited as blood donors, and they were recruited with the promise that this kind of genetic test information could make them still healthier. Then there was the question about receiving information about a genetic marker for an illness, where the implications to the donor relationship seemed much more mixed. It was considered that some might donate to receive this kind of information, while others to avoid donating to receive such information. So it was unclear whether it would benefit the donor relationship. There was also ambiguity around boundaries of when does receiving such risk information make a healthy donor into a patient in need of care and deserving of solidarity themselves. And if this would happen, whose would be the care responsibility of these patients or patients in waiting? And where would they get the diagnostic information to be made into something of health benefit? So finding these boundaries for solidarity when consenting to different types of genomic information, participants also reflected on the ethics of introducing this information to voluntary blood donation and to blood collection agencies in terms of what should be their core purpose in a society and within the healthcare system. Simon Cohen makes the point that research on donated blood constructs risk population and health intervention needs in ways donors have little control over and might not agree with when donating blood. From this viewpoint, asking donors' consent is important, but it's not enough if to make sure The future public interest of donors, patients, and those sharing their genome are to be respected when dealing with the outcomes of applying this information to practical use. To avoid conflicts of interest, donors should have a say in the process of deciding on which kinds of genomics information gets implemented by a blood donation process. The question for the blood collection agencies is how to best organize this involvement. Study participants also cautioned the blood collection agency for not to lose its identity as a trusted mediator of blood products by becoming seen as a provider of medical care for healthy donors. And while study participants expected the blood collection agency's genomic tests to benefit the healthcare system, they also expected the organization to act responsibly to maintain donor trust in their capacity to protect donor and the patient health and the privacy of their data. This seems to require investing resources on blood collection agencies, data processing, and its medical expertise. It is a political question as well as an ethical one if such investments are warranted in terms of added value to public health and to the strengthening of the donor relationship. So if adding more of these genomic tests to the gift relationship and biobanking of donors' genetic information will become new additions to the blood collection agency's purpose, these developments change what has been its role within the healthcare service and innovation infrastructure. It is still to be seen how exactly these changes reflect on donor relationships. Hetta Tarkkala and others observe how to donate genomic information for research and development purposes has been represented a new norm of civic solidarity, just with the promise of wealth, now coming first the promise of health. Busby notes how genomic information collected from volunteers to benefit the public welfare can be used for purposes outside the gift relationship and the national context, and also for private profit interests. Within this more complex ethical context, it can be harder for the blood collection agency to make a case for civic solidarity as the reason to donate genetic data. Personalized medicine has promised making medical treatments and prevention more efficient. This so-called precision medicine that uses genetic information and testing is presented being the state-of-the-art healthcare, so there is a public interest to access it. These promises take place at times when many countries have witnessed austerity and privatization of the welfare state services and increasing health inequalities. So what could the possibility of accessing genetic information at the blood collection agency mean in this context? Could blood collection agencies expanding to personalized medicine fill some of the gaps in the public sector? According to Alessandrini, quote, the community sector and its altruistic member organizations should not be compelled to take responsibility for the failure of the welfare state through neglect, end of quote. In this way, she argues, the civic society and the solidarity that creates social cohesion suffers the cost of privatization. According to Titmus, blood donor solidarity was about addressing health inequalities when the core purpose of the blood collection agency was to provide blood service for the general public. As this still appears to describe study participants' views on core purpose of the donor relationship, the legitimacy for blood collection agencies to collect and use different kinds of genomic information relates to the question of how this addresses the health inequalities of the present healthcare system. This study also underlines the importance of continuing this public dialogue with the current and potential donors about the possible health benefits, but also about the social and ethical implications of different genomic information. This is important if the blood collection agencies wish to avoid crossing boundaries or risking to miss out what for the donors makes the core ethical purpose for to be in this donor relationship. Thank you very much for listening to our presentation. If you have any questions or comments about the study, we would be really happy to hear about them.